Mr. Rami, thank you very much for coming today to the clinic. And as I talked with you over the phone, that we are here to discuss with you today the result of the lymph node dissection that was taken from your groin.
Thank you, doctor, and I hope the results are good.
Well, actually, out of the 16 lymph nodes that were dissected, 2 of them were found positive for melanoma. And this looks like a recurrence of your previous melanoma diagnosed 3 years back.
Yeah, but my melanoma in the trunk was removed 3 years ago, and I was totally fine. How did it come back?
Well, actually, and unfortunately, even for early stage cancers, there is still a chance of recurrence. The good news that we scanned your whole body with a PET CT and we did not find any evidence of disease apart from these lymph nodes. And we have also done some studies on a BRAF gene and we found it not to be mutated. I'm sure there are things we can do so we can reduce the risk of this disease coming back.
This patient has disease limited to nodal recurrence, which is completely excised, and the patient is currently disease-free. According to the NCCN, the adjuvant options in this case include checkpoint inhibitors of either Nivolumab or pembrolizumab or dabrafenib, trematinib for BRAF V600 mutated patients. Also, Ipilimumab can be used if other checkpoint inhibitors have been used previously. On the other hand, Dacarbazine and carboplatin paclitaxel are all chemotherapeutic agents that have no role in the adjuvant management of high-risk resected melanoma. Although standard high-dose interferon alpha is an option, there is no rule for induction-only HDI in the adjuvant setting. Finally, while Ipilimumab at the dose of 3 mg per kilogram every 3 weeks for 4 doses is unapproved for the management of metastatic disease, this dosing schedule is not approved in the adjuvant setting.
Well, we can offer you a treatment that we feel very good about. It's called Nivolumab, which is an immune therapy. And the basic understanding of it that it takes the brakes off your immune system and allow it now to attack your cancer.
I heard about this medication, but I'm worried about the side effect. I read that it can cause lots of problems.
Programmed death 1 or PD1 is a protein expressed on the surface of the activated T cells. When PDL1 or PDL2 binds to their PD1 ligand, the T cell becomes inactive. This is one way that the body regulates the immune system to avoid an overreaction to an insult. However, many cancer cells express PDL1 on their surface to inhibit T cells from attacking them. Nivolumab blocks PDL1 from binding to PD1 and hence promoting the T cells function against the malignant cells. However, this mechanism of action can also unleash the immune system to attack normal tissues, causing various underlying inflammatory side effects, including colitis, thyroiditis, hepatitis, dermatitis, and hypophysitis. While autoimmune pneumonitis, including severe fatal cases, have been reported with the use of Nivolumab, pulmonary hypertension, on the other hand, is not a recognized side effect of this drug.
I would like to discuss with you one of my patients. He's a 48-year-old male patient, very pleasant, and he was diagnosed with stage 3 melanoma. The primary was in the chest wall, and there was a clinical nodal disease. Actually, he underwent a wide local excision with lymph node dissection, and the melanoma breast lobe depth was 2 millimeters, and there is no ulceration. He has 20 lymph nodes removed in the neck, and 3 being macroscopically involved with cancer, but there was no extracapsular extension.
Is that Mr. Kumar? We discussed him at the MDT last week. I think I remember him. And I think we agreed to give him adjuvant immunotherapy.
Correct. This is a patient, but unfortunately he is not keen on starting immunotherapy because of the side effects. Actually, he has been asking me whether he should be taking radiotherapy.
Right, okay. So could you just remind me about the margin?
The margins were clear.
Right, fine. Well, I think there is a route for radiotherapy here, particularly as he's got a risk factor for disease recurrence. Do you know what this factor is?
One risk factor?
A risk factor. Adjuvant nodal Bayesian radiotherapy is indicated in high risk of recurrence melanoma patients. Features that are associated with regional recurrence include large lymph nodes, multiple positive lymph nodes, and the presence of extracapsular extension. And these vary depending on the anatomical site. For example, the risk criteria for cervical metastases include the largest lymph node 2 or more centimeters, or 2 or more involved lymph nodes, or the presence of extracapsular extension. For axillary metastases, the criteria are the largest lymph nodes more than 3 centimeters, 4 or more lymph nodes involved, or the presence of extracapsular extension. The following may also be considered as high-risk features where adjuvant radiotherapy may be helpful. Positive margins, 4 or more lymph nodes involved, extracapsular extension, bulky disease more than 3 centimeters in size, cervical lymph node location, and recurrent disease. Of note, adjuvant radiotherapy is associated with reduced lymph node field recurrence, but it has shown no improvement in the relapse-free or overall survivals.
Mr. Flaherty, thank you for coming to the clinic to talk about the treatment option for your melanoma disease.
Yeah, thank you, doctor. Of course, but I'm really getting frustrated with the whole situation. I'm sure that you understand why.
Well, I fully understand, Mr. Samer. I understand your frustration. You are 45 years old, and what we did so far is we did for you the X-ray and the CT scan of the whole body, as you know, and we found that you had multiple lung lesions, and we took biopsy from that, and the biopsy confirmed the presence of melanoma, and we checked for a mutation that we call BRAF, and we found this not to be present. So we're here actually to talk about what treatment options do you have, but before that, do you have any concern about the treatment?
Yes, doctor, yeah, indeed. I know it is incurable disease. I know that any treatments are given to try to extend my life and control the cancer, and I'm willing to take any options you would offer for me. But also I'd like to mention that I would like to try treatment that has got the best results with the minimal side effects, because I would love to live my life as normal as possible. So what options do we have here, doctor? As this patient is a BRAF wild type, he would not be a candidate for BRAF MEK inhibitors therapy. Ipilimumab has been shown to provide a long-term response in patients with stage 4 melanoma. This drug has been demonstrated to be superior to Dacarbazine. Nivolumab is another option. In the phase 3 Checkmate 067 trial, Nivolumab increased the average progression-free survival by 4 months compared with Ipilimumab alone. The benefit was even greater in the patients treated with the combination of Nivolumab and Ipilimumab. Patients treated with this combination of Nivo-Ipilimumab had a median time to disease progression of 11.5 months. For this reason, Nivo-Ipi should be offered as a frontline therapy to this patient. Finally, treatment with high-dose bolus interleukin-2 was the first effective systemic immunotherapy for the treatment of advanced melanoma. Interleukin-2 treatment is associated with prolonged survival in a minority of carefully selected patients and may actually result in cure. However, IL-2 treatment is associated with severe and potentially life-threatening cardiovascular, respiratory, and infectious complications, and its use has been replaced by the development of more effective and less toxic checkpoint inhibitors immunotherapy.
We hope you liked our video. This is Acting for Clinical Education.
And don't forget to check the reference down below.
Please like, share, and subscribe. And don't forget to join us every Thursday, 5 p.m. Greenwich time.